Hi everyone, in this video I'll be discussing another antibacterial drugs and they are protein synthesis inhibitors. Particularly the focus will be on tetracycline and chloramphenicol, which are called as broad spectrum antibacterial drugs. Now these are not only antibacterial drugs, they also act on other protozoa also, so we can call them as broad spectrum antimicrobials. So we'll start here. They are protein synthesis inhibitors. So protein synthesis inhibitors. So protein synthesis inhibitors, how to understand this topic. Now we need to understand that from DNA, this is the DNA, from the DNA we get the RNA. Now this is done by the enzyme that is called DNA dependent RNA polymerase. So it is called as DNA dependent RNA polymerase. Now that will give rise to the messenger RNA, that is mRNA. Yes. Now this messenger RNA is the one which is going to give the message for synthesis of protein. So this mRNA, what I have written here, has two important ribosomes, the 50S and the 30S. So we have a different ribosome, 60S and 40S, that's why they don't affect us. Bacteria have different 150S, 30S, that's why they are affected. Now, first of all, the process is initiation of protein synthesis. Right. Now, let me expand that and explain to you in detail. You have studied that in biochemistry, just a recap for you. Now, in this protein synthesis, we have something called the A site called acceptor site and a P site called promoter site. Now, this promoter site initially will have some amino acid attached to this. Now, the remaining amino acid has to come and get attached. So, there is an RNA called transport RNA, or what we mean by the tRNA. So, we have the transport RNA which carries the amino acid. So, the tRNA. So, there is an enzyme called isoleucyl tRNA synthase. So there is something called isoleucyl tRNA synthase, and that is responsible for making the tRNA. And this tRNA comes, first thing is it will come and produce the attachment. So the first step is called the tRNA attachment. So the tRNA attaches, that is called tRNA attachments. Now once the tRNA attaches there, it will bring the new amino acids. Yes, it has bought that. Now this already present amino acids have to go here and they will attach to the new amino acid and they will form the second process. They will form the second process, and the second process is formation of peptide bond. So there is formation of peptide bond. So once the bond is formed, the entire newly formed amino acids again go back to the P position so that the new amino acids can come and sit. And the third process, moving back from A site to P site, is called as translocation. The step is called translocation. Now this is how the amino acids are added and you get a peptide change. Then it is cut and protein is made. Now if you want to stop the protein synthesis in the bacteria, tell me where do you target? Tell me where do you target? So let me tell you, before coming to that point, there is a drug which can inhibit the DNA dependent RNA polymerase, and that is called rifampicin. So rifampicin basically inhibits RNA synthesis, because if you inhibit that enzyme, the messenger RNA is not synthesized. Particularly the drug is used to treat tuberculosis and leprosy mainly. And we discuss that in detail when we come to TB and leprosy. Clear? Now, the drug which inhibits the isoleucyl tRNA synthase, the name is called mupirocin. Now mupirocin is used topical. Where do you use it topically? Topically, it is used for skin and soft tissue infection, and also it's a drug of choice for very important condition, MRSA carrier states. MRSA carriers, to remove the carrier state, the drug of choice is mupirocin, and that is a mechanism of action. It inhibits isoleucyl tRNA synthesis. Very much important. Now let us come to the actual drugs which inhibit protein synthesis. Remember the tRNA attachment. So remember T for the drugs called tetracyclines. The name is tetracyclines. Yes, the name itself is telling you tRNA attachment. It is tetracycline. Peptide bond. This formation is inhibited by a drug called chloramphenicol. Now chloramphenicol sounds like fevicol. So fevicol is for bonding. So that is blocked by this chloramphenicol. Translocation step is blocked by the MCQ drugs. Now you remember, like if you solve the MCQs, obviously you will be translocated to the PG level. So M stands for the macrolides and C stands for the clindamycin, and the Q is a combination of quinoprestin plus another drug called dalfoprestin. And these group of drugs are called streptogramins. And this is the point. So MCQ. Now apart from this, we can also stop the initiation. That is the fourth important step. Now what is the first letter in alphabet? A. So the initiation is blocked by aminoglycosides. So aminoglycosides can block this. And one more drug, a beautiful drug nowadays used for tuberculosis, it is linezolid. So these are the protein synthesis inhibitors. I'll repeat again. Tetracyclines inhibit tRNA attachment, chloramphenicol peptide bond, MCQ drugs, peptide bond formation, macrolide, clindamycin, the streptogramins, initiation, aminoglycoside and linezolid. Now there are certain few drugs which are also inhibiting protein synthesis. The drugs which inhibit protein synthesis. Apart from this, just an additional point for you. So one of the drug is puromycin. So puromycin causes premature chain termination. One more drug are called pleuromotilins. So in pleuromotilins, we have a drug called, it is called retapamulin. So this is used topical. The drug is used topical for skin and skin structure infection. That's it. So these are additional protein synthesis inhibitor, but mainly you have to concentrate on the four important classes what I told you. Okay, we are clear with this. Now once we are clear with this, let us write certain specialties of protein synthesis inhibitors. What are the specialties? Now what drugs bind to 30S and what drugs bind to 50S in these ribosomes? Remember the drugs which bind to 30S, you can remember by the mnemonic T. Now T stands for the tetracyclines and AM stands for the aminoglycosides. And others, rest all bind to 50S. But linezolid has speciality. Linezolid bind to 23S fraction of 50S. 23S fraction of 50S, that is linezolid for it. So remember the mnemonic team 30S. So that is one specialty of protein synthesis inhibitors. Second question is, which of these protein synthesis inhibitors are cidal? I am talking about the four things what I have written. Cidal. Now the aminoglycosides are cidal, AGs, and a combination of quinoprestin plus dalfoprestin Individually they are static, but the combination is cidal, so we call them as streptogramins. Right? What is the static drugs? Rest all. Rest all are static drugs. So what are the rest all, sir? Tetracycline, chloramphenicol, amylglycoside. Let me repeat again. Rest all means tetracycline, chloramphenicol, macrolides, clindamycin, individually quinquistin, dalfustin. Individually they are static, only combination cidal. Then the linezolid, they are all static. So cidal drugs are these. So if you know cidal, static is easy. Now moving on to the third important aspect. In proteasase inhibitor, what is the mechanism of resistance? Mechanism of resistance. So number one, they can produce inactivating enzyme. So inactivating enzymes like beta lactamase can be produced here. And which drugs are going to be having these type of resistance are the amyloglycosides AGs and chloramphenicol. Chloramphenicol will have this problem. Second important thing is, what drugs are thrown out by a flux pump mainly? The drugs thrown out by a flux pump are mainly the tetracyclines. Tetracyclines are thrown out by a flux pump. Now, number three, the methylation of 50S. So that means alteration of target. So altering the target. And which drugs have this problem? It is by the MCQ drugs, macrolide, clindamycin, quinaprestin, and alfaprestin. So all the mechanisms may be present, that is inactivation, inhibiting the entry of flux pump, or by altering target, but these are the main mechanisms of resistance for these drugs. So main mechanisms, all are seen, but this is the main mechanisms for them. So once we understand the general aspect of protein synthesis inhibitors, let us go to the most important drugs, tetracyclines and chloramphenicol. They are called as broad spectrum antimicrobials. Broad spectrum antimicrobials. So in that first one we are going to discuss, and the name of that is tetracyclines. They are tetracyclines. So let us recap the mechanism of action quickly. Now you have to recap these things. It binds to 30S. Is it static? Yes. Now what step in protein synthesis it inhibits? It inhibits the tRNA attachment. So it is mainly protein synthesis inhibitor. That is the first thing you have to keep in your mind. So coming to the spectrum, we told it's broad spectrum. Now why it is broad? Because it can cover the gram positive, it can cover the gram negative, it can cover atypical bacteria. So what are the atypical bacteria like chlamydia, mycoplasma? Those are also covered. It can be used to treat leprosy, protozoa like amoeba. You can treat malaria with that. That's the reason. But tetracyclines are ineffective. Very much important. They are not going to work on ineffective. They are not going to work on that organisms. What are those? The TB. It's not going to work on that. And the gram negative, the family is called Enterobacteriaceae. So in that we have the E. coli, the Klebsiella, then the Salmonella, Protease, Shigella. For all these things, it is not going to work much. Now the question is, commonly asked question, will it work on Pseudomonas? No. Pseudomonas, it will not work. Very, very important point, because these are the organisms which they keep on testing you in the exams. Will they work on E. coli? No. Klebsiella? No. Pseudomonas? No. They are not going to work, and they have acquired resistance for that. They are not going to work now. Nowadays they don't work. Okay. So once I understand this, What are the drugs here? We know that the older ones are tetracyclines, and if you add oxy for that, you get oxytetracycline. If you add chlor to that, you get chlorotetracycline. Now, one more older drug is called demiclocycline. The name is demiclocycline. Now we have come across with newer ones. The name is called doxycycline, and one more drug is called minocycline. One more drug is called minocycline. I'll tell you one more drug. From minocycline, we got one more thing, and that is called tetracycline. Now, tetracycline has same mechanism like tetracycline. It is called as glycyl cyclines. So this belongs to glycyl cycline. It's a separate group, but same mechanism of action. We'll discuss about this drug later. So it is a derivative of minocycline. Now, right now, we'll be discussing the difference between the older ones and newer ones. What is the difference here? Now, the older ones, the problem was they were incompletely absorbed. Incomplete absorption. Incomplete absorption. Okay, sir, what happens if it is incompletely absorbed? Obviously, they will come to the intestine and kill our normal flora. What happens if they kill the normal flora? Obviously, they will cause diarrhea. So, the chance of more diarrhea is there. These drugs have good absorption, good oral absorption. So, since they are absorbed very good, they are not going in the gut. So, there is less chance of diarrhea. Less chance of diarrhea. These older tetracyclines, they form complexes, so they have food interactions. Food interactions, so you cannot give it with calcium, that is milk. So the tetracycline will form a complex with milk. And what happens? Milk contains calcium. Calcium and tetracycline will bind, and tetracycline will not get absorbed. Any ions like antacids, they contain the magnesium and the aluminum, they form a complex. Even it forms a complex with iron. So it has more food interactions. Now that interactions are less. So less food interaction, so you can give it with food, you can give it with milk. The drugs are doxycycline and minocycline. That's the reason why these are safer to use nowadays. So that is a difference between the older one and the newer one. Doxy, minocycline, they have good oral absorption, less diarrhea, and less food interactions you can give them. Now, coming to the story of doxycycline, pharmacokinetically, if I tell you, doxycycline is eliminated completely by bile. It is eliminated in bile. Okay, sir, if it is eliminated in bile, what should I know for that? The advantage is, if it is going in bile, obviously, if a patient has renal failure, can you use it? Yes. The question asked is, no dose reduction in renal failure. No dose reduction in renal failure. So that is the advantage. Now, I told you there is a drug called glycyl cycline. Remember, the glycyl cycline drug is called tetracycline. The name is tetracycline. It also undergoes bile elimination. And please remember, tetracycline is also safe to use in renal failure. No dose reduction is required. The name is called tetracycline. Sir, what about minocycline? It undergoes renal elimination, so you have to reduce the dose of it. Very, very important. Sir, we understood the mechanism of action. We understood the difference between older one, newer ones. We understood the specialty of doxycycline, bile elimination. Then what should we know? Now, since these are broader acting drugs, the uses are also broad. So the uses can be remembered by the mnemonic large. So what is large? So let me tell you. L, the drugs are used in lymphogranuloma venereum, then leprosy, and one more L for leptospirosis. leptospirosis. A for they are used in managing atypical pneumonia. Sir, what organism cause atypical pneumonia? You know that it is by Mycoplasma, Legionella, then Chlamydia. So it can cover all. Then it is used in rickettsia. So rickettsial infections, it is the drug of choice. G for it is used in a condition called granuloma inguinale. And E, it is used in the management of entamoeba histolytica. What is it going to cause amoebiasis? So where do you use it? It is used as luminal amebicide. Luminal amebicide. So it is used as luminal amebicide, particularly the tetracycline. So we understood the large, sir. Then when you know the large, who is the large player? Large player stands for, it is used in pylori. H. pylori eradication we use it, and also plague it is used. Plague. Then who is the large player of this thing? Australia is McGrath. He used to bowl lead. He is a very tall, large player McGrath. McGrath for malaria. Now I told you why they are broad, because they also act on protozoa, malaria, and also they work on Mycoplasma. Now this bowler bowls. So McGrath bowls. What is that bowls for? Borreliosis. Then Bartonella, Brucella. So many are there. That's the reason why it is called broad spectrum. So borreliosis, Bartonella, Brucella, and Bala tinidiasis. So large player McGrath bowls correctly. So he bowls correctly. Correctly stands for cholera and chlamydia. So where does it bowl correctly? At what? At for acne. You know that doxycycline is used in acne. Where does it bowl correctly? Stumps. Yes. So it is used in syphilis and SIADH. So SIADH is not an infection, sir. SIADH, there was a drug called demiclocycline, and demiclocycline is used in SIADH, but not nowadays. Previously, we didn't have any drugs. We used to give demiclocycline. Sir, what about syphilis? You told syphilis, the drug of choice are penicillins. If the patient is allergic to penicillin, then we use it. The question is, sir, you are taught so many things, correct? But which one will be asked for the exam? So for that, most important, we have made one more thing for you. Remember this doxycycline as drug of choice. So what are the conditions where doxy is the drug of choice? So if you know that this much, if you minimum remember, that is easier to answer in your exams. So the mnemonic is BCG. So BCG vaccine, take it in RML hospital. RML hospital. So what is that B for? B for brucella. So it is used in brucellosis, then Bartonella, and borreliosis. So here it is, drug of choice is, yes, what is it? Doxycycline. Then C for chlamydia and cholera. So we don't currently have the cholera, but it will be asked. G for granuloma inguinale. And most important, they will ask you is rickettsia infection, scrub typhus, Q fever, whatever it is. The drug of choice is doxycycline. Please mark this. And M for Mycoplasma hominis, L for an STD, LGV, and leptospirosis. These are the conditions where doxy is considered drug of choice. I'll repeat again. BCG-RML, brucellosis, Bartonella, borreliosis, chlamydia, cholera, granular inguinal, rickettsia, Mycoplasma hominis, LGV, and leptospirosis. So LGV and granular inguinal STDs, The drug of choice is doxycycline. Now there is one more infection called ballotinidiasis. So for ballotinidiasis, the drug of choice is tetracycline. Tetracyclines. Okay. Okay, sir, we understood the uses. Now, what are the adverse effects? Are we using the tetracycline in routine practice? Not much, because of so much of adverse effect, you will understand the adverse effect of tetracycline. Now, usually, most of the antibacterial drugs, they can cause allergy, that is hypersensitivity reaction. Second problem is they can cause diarrhea. So diarrhea is common. Why? It is called the super infection. What is super infection? Super infection. The reason is when we give tetracycline, which is broad spectrum, it will kill the normal flora, and the bacteria which are pathogenic, they will multiply more. And that's the reason why they can cause super infection, and that will lead to diarrhea. Now, what are the other adverse effects of this tetracycline? We can go and ask the tetracycline itself, but we'll make a mnemonic, and if I make more and more mnemonics, it's difficult to remember, so better to understand the concept here. Now the first concept is it's a broad spectrum. Now what is the problem if it is broad spectrum? It kills the normal flora, so it kills the normal flora. What happens if it kills the normal bacteria flora in the gut? Patient will have diarrhea. Patients will complain of diarrhea, correct? Now tetracycline is in love with calcium. Wherever there is calcium, it will chelate. So it will cause calcium chelation. So where is calcium in our body? Mainly, it is mainly in the bone and teeth. So it will cause bone damage, and it can cause the teeth discoloration. It can cause teeth discoloration and bone damage. So if it is doing this, teeth discoloration and bone damage, which group of patient we should never give it? It is contraindicated. Which patient? Obviously, we should not use it in a pregnant woman, because the fetus will have the bone damage. Children, the growing children require the proper bone, and lactation, it is contraindicated because of this problem. The next important is this drug will decrease the activity of ADH. Now what happens when you decrease the activity of ADH? Obviously patient will develop diabetes insipidus. So patient will develop diabetes insipidus. Now not all the tetracycline do that. A drug called demiclocycline will have this adverse effect. That is the reason why demiclocycline is used in the treatment of SAIDH, because it decreases the ADH. What is SAIDH? ADH is high, and this drug decreases the ADH. That's why it is the drug of choice. Now, whenever we think of tetracycline, remember tetracycline means 4. Tetra means 4. So it causes 4 important toxicity. What are those, sir? Please tell me. Number 1, it causes toxicity to the liver. It causes the toxicity to the kidney damage. So it is not seen with doxycycline because it is eliminated by bile. Keep that in your mind. The drugs can also cause photosensitivity. Sir, what is photosensitivity? It is nothing but when the patient takes the drug and goes out in the sun, he will have rashes because of the drug. And the maximum is seen with doxy and demiclocycline. These are known to produce that more. Now, one more toxicity is vestibulotoxicity. So vestibulotoxicity means the patient will have loss of balance. Who will do that more? And that is done by the minocycline. So minocycline is going to do that. That is maximum with that. Maximum. Now, these are the problems what we face with tetracycline: diarrhea, bone damage, teeth discoloration, diabetes insipidus, and tetrotoxicities. But the tetracyclines have one more special adverse effect. I will just tell you here. What are the other adverse effects? They have an anti-anabolic effect. They have anti-anabolic effect. Sir, what do you mean by anti-anabolic effect? That means they produce negative nitrogen balance. So they reduce the protein content in the body. The second important thing is they can increase the intracranial pressure. Very rare. It's not a common problem. Pseudo tumor cerebri. And one more important, if you're using outdated tetracyclines, outdated drug that is tetracycline, usually not used, but when it was used, they have found that it has caused Fanconi syndrome. So Fanconi syndrome, the tetracyclines will damage the proximal cameral tubule and patient will have the kidney dysfunction that is called Fanconi syndrome, and that is only seen with the outdated means expired tetracycline. So this is the adverse effect. If you know the concept, there is no need of any mnemonic for this. Okay, so just remember the adverse effect. Yeah, I hope you remember it in a conceptual manner. So once I know this, sir, are there any newer drugs in tetracycline group? Are there any newer drugs? Let me enumerate them. Newer drugs in this category. There is a drug called eravacycline. So the name is eravacycline. It is used in complicated intra-abdominal infections. Intra-abdominal infections. The name is eravacycline. Okay, so the name is eravacycline. One more drug is same cycline, but it is start with SARE. Cycline. It is used for acne. So remember that SARE logon ko acne. So when they are in teenage, obviously SARE logo acne, SARE cycline is support for that. Then we have omadacycline. The name is omadacycline, and that is used for community acquired bacterial pneumonia, and also it is used in abscess site. So what is that ABSSSI? It is nothing but acute bacterial skin and skin structure infection. It is called as acute bacterial skin and skin structure infection. They are nothing but folliculitis, carbuncle, furuncle, all those things come in that. So all those things come in that thing. Carbuncle, furuncle, folliculitis, all those things. That is called acute bacterial skin and skin structure infection. Yeah. I told you there is a group called glycyl cyclins. Glycyl cyclins, and the derivative is called Tetracycline. The name is Tetracycline. Advantage, I told you, it is safe in renal failure, and the drug undergoes bile elimination. So you need not do the dose reduction, but very, very important point, it is not useful in UTI. Not useful in UTI. Please mark this point. Very, very important. Okay, star mark. Because most of us think that tetracycline is such a great drug. Will it not work on UTI? No. One more drug is moxifloxacin. Again, it will not work in UTI. Tetracycline is used to treat the MRSA, VRSA infections. And also it is used in the management of New Delhi metalloproteinase 1. New Delhi metalloproteinase 1 producing bacteria. So it is being used there. So it is one of the reserved drug. We don't use it left and right for treating the patients. Because as we are moving in generations, we are facing with antimicrobial resistance. So whatever drugs we have antimicrobials, we have to preserve them. So that's why we should not use them for milder infections. So that is about the tetracyclines. One more broad spectrum The name is called chloramphenicol. The name is chloramphenicol. It ends like Fevicol. Again, it's a broad spectrum antimicrobial. But nowadays the problem is the drug has acquired resistance. So the usage of the drug has come down. Let us just summarize what we have already learned. It binds to 50S. It inhibits the formation of peptide bond. And is it static or cidal? Obviously it's a static drug, right? And it inhibits, main thing remember, protein synthesis. So it's a protein synthesis inhibitor. Now, if it has acquired resistance, why should we study that? Now, importantly, remember a pharmaceutic, it undergoes glucuronide conjugation. So the main conjugation reaction is glucuronide conjugation. So the adverse effect of chloramphenicol is it causes gray baby syndrome. So the problem here is when a newborn, particularly premature, are given high dose of chloramphenicol, this is seen. The problem is in a premature baby, the enzymes are limited, lesser, and the drug, when we give it, it's not metabolized, the levels increase, and that will lead to the problem called gray baby syndrome. Second important problem is the drug is known to produce aplastic anemia. Now, aplastic anemia in certain people, it is called as idiosyncratic reaction. Idiosyncratic reaction. Sir, what do you mean by idiosyncratic? Now, this aplastic anemia may not be seen with everyone, only in few people. That is the meaning of idiosyncratic, and it has some genetic problem. So they have some genetic basis to get this problem, aplastic anemia, and the drug can also produce bone marrow suppression. Yes, and your favorite, they can also cause diarrhea, nausea, vomiting, all those things you write. Those are the problem. Now, where do you use it, sir? Nowadays, you told they are resistant. Do we use it? Yes, it is used in topically. So, topically it is used as eye ointment. Topically it is used as eye ointment. Second, it is used for anaerobic infections, anaerobes, and also it is used in meningococcal meningitis. Meningococcal meningitis it is used. Now, what has happened is, since we thought chloramphenicol has acquired resistance, we stopped using that. Now, what is the miracle happened is, now bacteria are becoming sensitive to chloramphenicol again. So we can be using this again in the future. Now they are working on meningococci, they are working on anaerobes. So let us hope the future they will work on the resistant bacteria also. So let us hope that. So that's why chloramphenicol is still there in the market, and it will be the future hope. So we can use them in the future, hoping that it will kill the bacteria. So that is about the important protein synthesis inhibitor, that is tetracycline and chloramphenicol. So let me summarize these things in a nutshell. We are dealing with the antibacterial drugs, and the target is protein synthesis inhibitors. So here what we can do is, we can stop the protein synthesis. Number one, inhibit tRNA attachment, tetracycline, inhibit the peptide bond, chloramphenicol, bond, Fevicol. Translocation, MCQ drugs, macrolide, clindamycin, quinpristin, dalfustin. Initiation, A amylglucoside, linezolid. 30S binding are team, tetracycline, amylglucoside, cidal are amylglucoside and quinpristin, dalfustin. Then tetracyclines are broad spectrum antimicrobials. They can work on every bacteria, but they have become resistant to TB. They are not going to work on TB. They are not going to work on Enterobacteriaceae, E. coli, Klebsiella, Salmonella, Shigella, Pseudomonas. It will not work. So please keep that in your mind. Why it is broad spectrum? Because it will also cover atypical bacteria, and also it will cover the protozoa like malaria, amoebiasis. So the difference between older and newer ones is, the older ones, they have food interaction, they cause more diarrhea and less absorption, but the newer ones have very good absorption, up to 100 to 95% absorption. If you take minocycline, approximately 100% absorption, doxy 95% absorption. So Their chance of diarrhea is less and food interaction is minimal. Specialty of doxy and tetracycline is they are eliminated in bile, so they are safe in renal failure. You have to remember doxy as a drug of choice, BCG-RML, B for borreliosis, Bartonella, Brucella, then C for chlamydia, cholera, G for granuloma inguinal, R for rickettsia, M for mycoplasma hominis, and L for LGV and leptospirosis. What are the adverse effects? Let's go in a conceptual manner. Almost all the antibacterial allergy correct. They kill the normal flora because they are broad spectrum, diarrhea. Second, wherever the calcium they are in love, they chelate, so bone damage and teeth discoloration. Cannot be given in pregnant children and lactation. 4 toxicity, tetracycline, liver, kidney, then photo, that is skin toxicity, maximum with doxy and demiclo. Vestibular toxicity maximum with minocycline. Then they have anti-anabolic. They can cause pseudotumor cerebri. If you are using outdated tetracycline, they are going to cause Fanconi syndrome. Now, once we know that, tetracycline, again an important drug for MRSA, VRSA, and New Delhi metalloprotein-producing bacteria, but it is not useful in UTIP. Please mark that point. Then chloramphenicol is outdated. They can ask you, it is going to cause Gray baby syndrome, and it's a broad spectrum bacteriostatic drug. It inhibits peptide bond formation. So that is about the tetracyclines and chloramphenicol in a nutshell. Thank you all.